Very good morning to both the people in the audience here. So my name is Dr. Preethi Naveen, and I'm the instructor for this course, the chief instructor. I have with me my co-instructor, Dr. Sumati, and Dr. Ranjita. So our topic today is going to be about the management of a Descemet's membrane detachment, which is something which I think as cataract surgeons we all experience. And so I'm going to teach you the basic steps on how to manage a proper DMD. So we'll have Ranjita talking about the anatomy of the Descemet's membrane and the risk factors involved in a DMD.
Very good morning to one and all present here. I would like to thank the AOS committee for giving us this opportunity. And I will be talking about the anatomy, etiopathogenesis, and the classification of Descemet's membrane detachment. So, going by a brief anatomy, the Descemet's membrane is located in the posterior stroma and it measures about 8 to 10 mm in thickness. And it, along with the corneal endothelium, helps us in maintaining the transparency of the cornea. A brief histopathology. It's consisted of three layers. One is the non-banded layer, which is the thinnest, measures about 3.3 mm, and it's present just adjacent to the stroma. Then followed by the anterior banded zone and a posterior non-banded zone. The posterior non-banded zone measures about 4 mm and it represents about 2/3 the thickness of the Descemet's membrane. It's mainly made up of collagen type 4 and type 8. It is also made up of other non collagenous substances such as fibronectin, laminin, nitrogen, vitronectin, and it's also made up of other proteoglycans such as your keratin sulfate, the heparin dermatin, and chondroitin sulfate. So the etiopathogenesis, the Descemet's membrane detachment is a serious complication following cataract surgeries, and it has been characterized as a potential visual threatening complication, and it's reported to occur in almost 43% of all cases following cataract surgery. DMDs can also occur in any anterior segment surgeries such as your iridectomy, trabeculectomy, viscocanalostomy, vitrectomy, or any corneal transplants. It can also be found in some cases of chemical injuries as well. Most of the DMDs are not vision threatening and they resolve spontaneously after the procedure. And the characteristic clinical sign is a severe persisting corneal edema after the surgery without any spontaneous improvement. So, a hammock configuration, which is usually seen in a slit lamp, starts at the corneal ports of entry and is due to injections due to hydration. So, the fluid enters the potential space between the posterior stroma and the DM, separating the DM into various extents. And the detachment may be associated with the DM separation due to entry of fluid into the interface. The most severe kind is a complete tear separating the detachment into multiple flaps due to any iatrogenic trauma due to blunt instrumentation or during delivery of the nucleus in case of an SICS. The major risk factors can be classified as pre-op, intra-op, and post-op. In pre-op, any pre-existing conditions such as corneal neovascularization, old age of the patient, a dense cataract, or any previous history of chemical injury. Intraoperatively, in any clear corneal incisions, if the incisions are small or rugged, any blunt instrumentation or frequent instrumentation, any inadvertent damage by the instruments, and in case of phaco, when the ultrasound sound time exceeds more than 60 seconds. Post-operatively, if there is any abnormality in the Descemet membrane stromal interface, any corneal ectatic disorders or endothelial disorders such as your Fuchs. So, going by the classification, we have the Samuel's classification of DNB, which is classified as active, passive, and combined. So, in active detachments, it's also known as the pushed back detachments. So, this occurs due to any active exudation between the stroma and the DM, which pushes the DM backward. In a passive detachment or a pulled back detachments, this occurs due to any organizing exudates or heme present in the anterior chamber, which draws the DM into the anterior chamber away from the stroma. And then there are detachments because of the difference in elasticity between the stroma, that is the stromal parenchyma, and the glass membrane, causing the Descemet's membrane to roll on itself or form folds. Then we have the macule classification. This is divided into planar and non-planar. When the separation between Descemet's membrane from its overlying stroma is about less than 1 mm, we classify it as planar, and non-planar when it is more than 1 mm in any area. Obviously, the planar has a better prognosis than the non-planar. Both the detachments are further classified into peripheral and combined. So, in peripheral detachments, the peripheral 3 mm of the cornea or the DM is involved, and in combined detachments, both the periphery and the center is involved. Next is the Jane's classification. So Jane's classification is divided into mild, moderate, and severe. That is less than 25% of the cornea, from 25 to 50%, and more than 50% of the cornea. And good prognosis were observed in cases of air compared to C3F8, and poorer prognosis was seen in cases of advanced cataract, prolonged duration between the cataract surgery and any surgical intervention, and cataracts with pre-existing corneal opacities. Moving on to the help algorithm. So this algorithm is basically dependent on the classification using ASOCT, that is the anterior segment OCT. And this is useful for us to diagnose and plan the treatment protocol and also the prognosis. So it can be divided into three categories. First is HELP, stands for the height, the extent, the length, and the pupillary involvement. So in case of the pupillary involvement, it can be classified into three zones: zone 1, 2, and 3. Zone 1 involving the center, zone 2 involving the mid periphery, and zone 3 involving the far periphery. So the first one, when the height is less than about 100 microns and the length less than about 1 millimeters, when either of the zones are involved, 1, 2, or 3, we can go ahead with the medical management. Second category, where the height is between, so all these measurements are based on the ASOCT. So when the height is between 100 to 300 microns, length somewhere between 1 to 2 mm, again we classify it as zone 1, 2, and 3. Zone 1, whether the pupil is involved or not. If the pupil is involved, then surgical intervention would be the method. If zone 2 and zone 3, then we can follow medical management. If the medical management doesn't subside within 4 weeks of commencement of the treatment, then we can go ahead with the surgical management. The other criteria is height less than 300 microns, length more than 3 mm. If it is zone 1 and 2, surgical intervention is recommended. Zone 3, we can still observe medically. And again, if it does not resolve, we can go ahead with the surgical management. So this is an ASOCT picture of height about 100 to 300 microns, length approximately 2 mm. Zone 3, that is the far periphery, is involved. So going by this classification again, we can follow a medical management. So the first image is of a height less than 100 mm, length less than 1 mm, and zone 2 involvement. We can go in for a medical management. Again, the second picture is of a height less than 100 microns, length approximately between 1 to 2 mm, zone 1. So though the center is involved, since the length is quite small, we can still try for medical management. This is coming to the Jacobs classification. This is very analogous to the retinal detachment classification that we have. It is the Descemet's membrane detachment is classified into 4 criteria. One is the rhegmatogenous, tractional, bullous, and complex. So in rhegmatogenous Descemet's detachment, it's usually because of any hole, tear, or dialysis in the DM. And any small clinically insignificant tears, we can observe the patient. However, clinically significant tears such as involvement of the visual axis, we can go in for a surgical treatment such as pneumatopexy or fluid drainage, depending on what the cause of the DM is. Going to the tractional detachment, we have the tractional detachment is because of any incarceration of the DM into any sutured corneal wound, which causes a traction pulling the DM. Again, if it is small, we can observe the patient. However, if it is clinically or visually significant, we can go in for a surgical management. Any long-standing rhegmatogenous detachments can also lead to a tractional detachment because of the traction. Going to a bullous detachment, this is because of any fluid injection between the corneal interface and the DM. So the fluid can either be a viscoelastic or any during hydration. If it is again visually insignificant, we can observe and then go in for a surgical management if it is visually significant. Complex detachment usually occurs in any post endothelial grafts. So this is when the graft rolls on itself, leading to a complex presentation of the DM. So this is an example of a rhegmatogenous detachment. Usually in the rhegmatogenous detachment, there is separation from the posterior stroma and there is free floating of the DM in the anterior chamber. This is an example of a tractional detachment. So in a tractional detachment, the either ends of the DM is still attached to the posterior stroma and the DM presents as a taut membrane. So this adjacent picture is that of a slit lamp image of a patient. So this patient had an incarceration of the DM in a sutured corneal wound. So center we can see the detachment and in the periphery we can see the attachment to the stroma. This is a bullous configuration of detachment. The center can either be filled with a fluid or it can be filled with any viscoelastic material. So while going in for a diagnosis, these are the following things which we have to keep in mind. A thorough slit lamp evaluation and an ASOCT is pertinent for us to plan our treatment. So the configuration of the tear or the detachment is usually seen in an ASOCT. The material causing the detachment, in case of a viscoelastic, we need to do a drainage of the fluid, presentation of the DM, and also area and extent of the detachment. We should also be able to find out any areas of missing DM. So these features help us in surgical planning and in predicting the prognosis. So I would now like to hand it over to Dr. Preethi, who will be talking about the management of the detachments.
Thank you, Ranjita.
Thank you.
I'm not able to close this. No, close this thing. Presentation is something. Okay. The slides will come there. So I think Ranjita has given us in detail about the different classifications of DMD. So the issue with DMD is one is you will have to observe most of these cases before you decide to go in for a surgical intervention in these cases. And typically after a cataract surgery, when we all see this dense SK, that is when we get scared, maybe there is a DMD. But if you are the primary surgeon, you probably know what happened during the course of the surgery, whether it was a long surgery and that is why you are having the SK, or on table, if you did manipulate the DM, did you try to attach it on table with air? And those are some things which should come to your mind before you decide on your course of management. So the first option would always be a conservative management for a DMD. Okay. So your conservative management select would be mostly medical management. So the patient post-op would obviously be on topical steroids. In addition, when you notice a dense SK, you start putting them on hyperosmotic agents. And the role of hyperosmotic agents would again be to draw out the water from the edematous interface. And and if you feel that even after a week or something, if the SK is not clearing, I would suggest maybe get an ASOCT done if you have access to a machine at your center. And because sometimes even with hyperosmotic agents, we notice that the SK gradually clears. And a preoperative specular is very important in a lot of cases because that helps us to determine the post-op outcome of these patients. So conservative management would only be steroids and your hyperosmotic agents. You can start giving the Ripasudil eye drops, which we have been giving in a couple of patients, which works well. So I'm not going to the HELP algorithm because Dr. Ranjita has already spoken about that. And going to surgical management, the gold standard would be a pneumodesmetopexy. And yeah, so the common agents we use are air, we use SF6, and we use C3F8. So these are the concentrations in which the agents are used. And the viability in the eye is probably a week or less for air, and SF6 it's around a month, and C3F8 is around 2 months. And air is pretty simple. You just retract your syringe, and that's how you get in the air. But for SF6 and C3F8, you take in zero point 0.1 ml of the gas and dilute it with 0.4 ml for SF6 and zero point 0.8 ml of air for C3F8. And whenever you do SF6 or C3F8, obviously it won't be a full chamber air fill because these gases expand on themselves. So we do only a 60% of air fill in these cases. So the technique of desmetopexy, I would be showing you some videos, but this is just a brief stepwise approach for this. And so before you enter the theater, it's better to get an ASOCT4 documentation just to know the configuration and also the location of the Descemet's membrane detachment, because that's very important, as the site in which you're trying to inject has to be exactly opposite to the area of detachment, because you don't want to induce an added insult to the eye. So 1 second. I'll just show you a couple of videos. So is it shown there? This video has to play.
प्रेजेंटेशन में नहीं इसमें
हाँ,
नहीं
प्रेजेंटेशन यहाँ है, ये दोनों वीडियो को प्ले करना है अभी। ये ऐसे ही रहना दो।
सही है तो ये आपका एक्सटेंडेड मोड पे जा रहे हैं ना एक्सटेंडेड मोड पे जा रहे हैं
उल्टा हो गया, वीडियो उल्टा हो गया। नहीं, हाँ, ये नहीं हो रहा है।
ये अलग से प्रेजेंटेशन में शो होगा, वो एक्सटेंडेड मोड पे चला गया ना आपका, वो हटाना पड़ेगा आपको।
तो उसको क्लोज करना होगा आपको।
हाँ, उसको क्लोज करना पड़ेगा।
ओके ठीक है, तो प्रेजेंटेशन को खुला दो। प्रेजेंटेशन क्लोज करना था, वीडियो ओपन हो। Yeah, that's
मैम ये
okay.
वीडियो है, मैम का वीडियो है ये।
Video is not opening. So this is a case of what? Just a second. Okay. So this is a patient with a multifocal IOL who was referred to us from a branch, and she had a large bullous DMD and you know the configuration of bullous from what Ranjita has already explained to you. And she was a very unhappy patient because you know after a multifocal, obviously you expect a 6/6 vision post-op. And so this was her case. And so what we had to do was first is we'll have to identify the location of the DMD, which we felt that the detachment had occurred during the time of the stromal hydration of the main port. So that's where the detachment starts from. And so once you identify that, then we go ahead and with the use of an endoilluminator in people who don't have an access to an endoilluminator, you can always stain the graft. You can put in a Blurex into the anterior chamber, which helps you to see the position of the Descemet's membrane. And since we have an endoilluminator, we decided against it. So the endoilluminator helps us to actually feel where the DMD is. And what I'm doing there is I'm just giving a stab incision because it is a bullous detachment. So what we want to do is we want to egress the fluid from the interface, because just by putting air, the fluid in the interface is going to take a little longer time for it to absorb. So once we confirm it, we do a stab incision into the cornea, with a keratome, and making sure not to enter into the anterior chamber. And with strokes or with your cannula, you can just flush out the interface fluid. And since I know that it is in the direction from the main port, we go in the opposite direction. And now I'm injecting pilocarpine just to make sure that when I inject air, I don't have any air escaping under the iris on table. So once I inject pilocarpine, I prefer taking sutures. There are a lot of them who don't take sutures, and they feel that with SF6 or C3F8 they do good. And I personally don't use any of those gases. I use only air, and I think it really works well. Just a single suture at your main port and your side port should be enough. Just to keep the air for the 24 to 48 hours is the crucial period for the DM to attach. And you could remove your sutures within a week. So we just take a bite, and then that's the direction in which I would be injecting my air, because that's where the DMD is there. So opposite to the location. And once I inject air, try and keep it as a single bubble, because the smaller ones absorb faster. And so one large bubble. And you would have noticed that we didn't, so again, I'm flushing out the interface, and I feel that the airfill is not adequate enough for me. If it was a gas, I would have done this much, even less than this, because it has a tendency to expand. But since it's air, I want probably a 90% airfill at least for some time. So I go in with a 30 gauge needle and a 2 cc syringe, and the cannula facing away from the direction of the DMD. We enter a little at the limbus, making sure you don't strip the DM at that position again. And you use a bud as you retract outside so that the air doesn't escape through your entry wound. And finally, I egress the fluid out a little more, and that is her post-op day 1 picture. The patient was very happy, and even though the air bubble has reduced, the DM has attached itself well, all because of the suture, which has kept the air in for the necessary required time. And I haven't done a PI in this case, but a PI can be done in most cases, but I usually don't do that because I don't fill 100% air, so there's no chance of a pupillary block happening there. So this is a post-op day 1, and I'll show you another video. Okay, so this was a little more complex case because it had a larger DMD, and as you know, the surgery was again operated elsewhere and referred to us. Again, we use the endoilluminator over here. In cases where you feel that the visibility is poor because of the dense SK, you can always peel off the epithelium so that you have better visualization. And I put in a pilo always to constrict the pupil, and redo the sutures if I feel they are too tight, and assessing with the endoilluminator as to where the DMD is. So, and like I told you, always in the opposite direction of the DMD. And if you feel that you're still not able to identify it, like I told you, you could put Blurex or you could put short gushes of saline, so that you can see the DM fluttering in the AC, and then you will know the orientation of it. So all this is, both these cases are bullous and rheumatogenic type. None of them were the taut DM types. And so a similar way, we take a 30 gauge needle, bevel facing towards the opposite direction from the DM, and we enter inside. Here you can see, because as the eye was soft, I did have some entry into the stroma. That's where you see those air pockets there. And we inject the air, again a full chamber air, and making sure you close the wound before you're exiting over there, and flushing out the interface. Here I didn't do a stab incision because it was more of a rheumatogenic and not a bullous DMD where there was fluid stuck in the interface which we had to egress out. So this settles by just the airfill over here. And yeah, going back to my presentation. So each case, I think the management would differ based on the type. If it is a taut DM, then you would have to release the attachments at the periphery, because just by putting in air, it is not going to settle. You will have to use a 26 cystitome, which is bent in the reverse direction, and just try to release the DM at the periphery so that the DM attaches well. So classify your detachment prior to deciding your treatment plan. So now once we've done the air injection, what we do is we typically tell the patient to lie down at least for an hour in the OR or the recovery room, and then we remove the patch after an hour or so to reassess whether there is a full chamber air and the patient is having too much of pain. Then we would release some air. We could burp a little air on the same day. If the patient is comfortable, we send them back, advising them to have a supine position for the entire day. And so the problems which you can experience with a desmetopexy is, the most common thing is your raised IOP, which is because of a pupillary block. So how do you overcome this? One is by doing a surgical PI on table, or not giving 100% airfill on day one. And I would weigh the pros and cons of 100% airfill versus a pupillary block. I would say do it and then, burp the air after 1 hour so that it doesn't go into pupillary block, rather than just fill the chamber with 40% air, which is not going to help in any way. Because again, you'll be having to take up the patient for a repeat surgery, which is something which they don't appreciate. So the other thing is, on day one, patients are fine, but the second day they present to you, you have the air going behind the iris and you have a synechia formation there. So in those cases, what you can do is just put a drop of T plus in your clinic, make them lie flat. You will see that the air comes out into the anterior chamber, and that itself should be enough. Very rarely we've had to take up the patient to release air in the theater and form the chamber again. But these are some things. You could give mannitol and Diamox if you don't want to take in the patient once. But the minute you notice a synechia forming, I think you will have to release the air and form the chamber with saline at least. And so again, endothelial fallout if there is any inadvertent instrumentation during your procedure. And sometimes when the patient comes to us after a month of a DMD which has not been identified at a peripheral center, they would have already developed some amount of haze because of the scarring over there. So you can still reattach a DM even after a month or two, provided you're able to, again, like I said, identify the location properly and detach the adhesions there and put in air, it settles well. And sometimes you end up with an irregular astigmatism if there are too many DM folds in spite of you putting in the air. So when you put in air and you notice that the cornea is totally clear, then you're fine. But if you notice a lot of wrinkles in the decimates, you can go inside and try to iron out the wrinkles with the help of an air pump, which you can use. So that helps in, so you might have felt that you have put in air, the DM is attached, but functionally they are not seeing well because of the folds which are present in the DM. So I feel you should unfold them at the periphery to make it better. So post-operative pupillary block we've spoken, and the stab incision is something which I had shown you in the video. And post-operatively, the medications would be topical steroids, and you could put them on hyperosmotic agents if you still feel that there is some amount of edema. Otherwise, there is no need to continue them on that. And sometimes we have had patients where there is inadvertent injection of viscoelastic into the interface. So visco is a little difficult to get it out as compared to fluid. So you will have to use similar stab incision, go into the pocket and try to aspirate the visco out, because you can't egress it out just by movements on top of the cornea. It doesn't happen that way. And tamponade with other agents. Suturing, some of them have done a transcorneal fixation of a detached DM. In cases where we feel that multiple air injections have been done and we still feel the DM is not attaching, you could do a suture, but you'll have to be very careful about handling the DM at those places. And the other techniques are manual repositioning with a spatula. Then the scar, like I told you, how to prevent, you release it, and then you attach the DM. And in cases where, so we have tried DM attachment, and sometimes maybe it is a long standing and the initial trauma was too much. In those cases, if you feel your air injections are not working, or the air injection has worked, the DM has attached, but it hasn't regained its functionality, then I think it's better to go in for an endothelial keratoplasty at that stage. These are some of the pictures, pre and post pictures of air injections. And you can notice all my air injections have sutures in them, which I remove in a week's time. And I don't know if they're okay. So this is another large rhegmatogenous detachment which we settled with air. And so I think the take-home point is DMDs can do well if managed at the right time, and the right area, site of air injection, and if you follow the techniques, I think DMDs will do well. Thank you so much. I think I'd request Dr. Sumati to come and for her talk on PDEC in cases where our DM attachments have been unsuccessful.
I thank the organizing committee for giving us the opportunity to present in this AIOS conference. There was a extensively covered topic by Dr. Anjita and Dr. Preethi about the classification and the initial management when you have a small DMD or anything, like you can manage, how you can manage in a conservative as well as your desmetopexy. Okay, what next will be the situation, like you have patients where you have repeatedly injected air and the DM has not settled, but the cornea is not cleared. And if you have a case like DM is settled with your air injection, but the corneal edema still persists. So what eventually happens is the cornea doesn't clear. You can wait for 4 weeks to a month minimum, and then see like the cornea is not cleared, then eventually you will have a patient with an bullous keratopathy. You can have a situation where patient has been with your follow-up and you know what is happening with the patient, and maybe in a month's time you will be having a patient like, okay, the patient has gone in for endothelial decompensation, and your decision will be straightforward, like you can go in for an endothelial keratoplasty. Believe me, there will be many situations where patient can present at a very late stage, where you have to take a decision whether you contemplating whether you have to go for an optical keratoplasty or an endothelial keratoplasty. So this is a flow chart which I have made. Like you can actually, when you see a patient, first look into the stromal scarring is there in the patient or not. The stromal scarring is very important. You have to analyze whether patient is having a stromal scarring or an epithelial hypertrophy or an epithelial scarring. Why mainly is, if patient is really having an epithelial hypertrophy or an scarring, you can still go away with the endothelial keratoplasty. But stromal scarring definitely is, even if you do one endothelial keratoplasty, the patient is not going to get a good vision, and your visualization definitely will be very difficult for an endothelial keratoplasty. So stromal scarring definitely is. Then you look into the other parameters of your anterior chamber, whether the IOL is stable and the iris parameters. If your IOL is stable, then definitely it goes either into an optical keratoplasty if scarring is there, or if there is no scarring, then endothelial keratoplasty. But if your IOL is not stable, then it goes in for a combined procedure. What are the combined procedure which we have to think about? Okay, first is the IOL. Then if you have an ACIOL or an PCIOL decentered, or an patient is straight away with an aphakic patient, or your drop IOL in the vitreous. So if it is an ACIOL, you just explant the ACIOL and combine it with the gluteal, which usually we practice. And if it is a PCIOL decentered, again, if it's a single piece or a 3-piece IOL, then you can reposition the same IOL with the glued IOL. If it is a foldable IOL or some different IOL where you cannot reposition the same IOL into a glued IOL, you explant it and combine with a glued IOL procedure. So aphakia, then straightforward glued IOL, and IOL in vitreous goes with your pars plana vitrectomy, IOL explant and with a glued IOL. So then comes your iris status. So iris is very important because, like, believe me, like if something has to go wrong with a surgeon on table, it can go wrong in all situations. Like maybe sometimes you have a PCR and with added to your iris may be coming out. You can accidentally have an iridodialysis, or you can with your Fico probe or anything, like even the iris tissue can be pulled away here and there. And then to add on your spice on your table is your DM detachment. So iris status, like if it is only a dilated and a fixed, then you can only consider doing in a single pass pupilloplasty. If it is an iridodialysis, you can repair it with whatever the technique which you are comfortable. And if you have PS with an irregular pupil, you release the pass and then combine with your SFT. Managing iris is very important, mainly because when you inject a graft into your anterior chamber, the iris should be, a contour should be smooth, mainly because it has two components of its action, that is its axis and scaffold when we are unrolling your graft. And iris tissue hanging here and there, like it also incite a inflammatory reaction. So always fixing the air is very important, and staying of your air into the anterior chamber is very crucial for your graft to get attached in case of your endothelial keratoplasty. So what endothelial keratoplasty types like we have is DSEK, Descemet stripping endothelial keratoplasty, Descemet stripping and automated endothelial keratoplasty, DMEK, that is Descemet membrane endothelial keratoplasty, and your PDEK, that is pre-Descemet endothelial keratoplasty. So I'll show you the videos of what we practice is the PDEK. This is an initial case where it was just a straightforward case, like a simple IOL was stable, and only patient presented with a bullous keratopathy, and little DM scarring was also there. Pause. How do I pause it? How do I pause it? Pause it. Pause कैसे करना है? वो नहीं आ रहा. It's okay. Oh, that is not coming. Directly video से कर सकते हैं.
Yes. Yes.
Hmm?
Just
No, the pause வரமாட்டேங்குது. It's okay.
is there any audio?
It's coming to that and the pause button.
Audio. Yeah.
No, it's going up to the next one. Pause button. Skip button. It's okay. Okay. Skip button. Okay. Sorry. Yeah, this is a case like where First, before going into the case, we have to prepare the graft. This is like a donor tissue with the endothelial side facing up. You inject air into the stroma with a 30 gauge needle, which is filled with a 5 ml syringe. Once you inject air, you can see multiple small bubbles in the center. Like there we go, realign your needle again, and then start injecting. You can get a type 1 bubble, that is a bubble which air separates your PDL from your posterior stroma. Once you get this bubble, then you make a knife entry into the bubble, that is from the base of your bubble, and then you can inject a trypan blue to strain the graft. Once that is done, you can cut the graft tissue from the underlying stroma using a Vanna seizure. So with this, like, you can separate the graft. Once you have prepared the graft, you can keep the graft in the preservative media till you prepare your patient. So this is a case like where you can see there is a lot of DM scarring is there. Uh, and the IOL is stable, and the first thing which you do is you fix your trocar ACM, that is like from the 1 mm from your limbus you fix a trocar ACM, so that the trocar faces towards the center of the eye, and the trocar just enters the eye above your iris, so that you can have either your continuous flow of air or saline into the anterior chamber. So the advantage of this trocar is like with the continuous flow of air chamber, your chamber is maintained very well. You need not have an viscoelastic to be inside your anterior chamber, so that you have a for the descemetor axis you need not have a shallowing of AC frequently. And if you use a viscoelastic, then you definitely would like to have a thorough wash of your viscoelastic from the chambers, because it might interfere into your endothelial graft attachment in the postoperatively. So once you make your two side sport entry, you make a descemetor axis. You can go around all round, so that you can score the Descemet's membrane very nicely, and then you enter the cornea with a 2.8 keratom, making a main port wound, so that you can remove the Descemet's membrane which you have scored already. And once the Descemet's membrane is out, you have to check the for the remnants of your Descemet's membrane still attached into the any of your parts of your cornea, and then you do an inferior iridotomy, so that you will not have an pupillary block in the postoperative period. This is a graft which is being loaded into the injector with a preservative media, and then once you load the graft into the injector, you switch off the air pump, and so that only saline is there in the air in the anterior chamber, and then you inject your graft in the anterior chamber. So once your graft is there in the anterior chamber, you have to suture your main wound. That is the main first thing which you have to do, because once you don't suture your main wound, the graft can egress from your main wound. So with the endoeliminator, you have to look for the correct orientation of your graft. How you understand the orientation of your graft is Descemet's membrane always has a tendency to scroll towards itself. So the scroll should be facing up towards your microscope. That is, when you are looking through the microscope, the scroll should be facing up towards you. So once that is you confirm the graft is in the correct orientation, you can start unrolling the graft, like keeping the anterior chamber in a shallow and a gentle tapping of the cornea over the cornea. Once the graft is unrolled, you can inject the air into the anterior chamber, and then the graft is very well attached. So you can confirm with your endoeliminator all over. So the advantage of your PDA graft is you can, once the graft is even unrolled in the periphery, you can pull the graft in total with your reverse Sinskey hook, so that you can get the graft to the center. But the same thing cannot be happened with your DMD graft, mainly because it's thin and flimsy. The handling of the tissue might be very much difficult. So once the graft is very well attached, you have your anterior chamber full, then you can suture all your wounds, which is very important. And this is the postoperative day 1 picture of the same patient, and this is 1 month post-op. You can compare with the pre and post picture, and 3 months post-op picture. So this was a case of straightforward case, and there's one more case like where I'll show you where we did a combined procedure. This is another case like where maybe because of repeated air injection, the desmoid membrane was almost edematous and lot of inflammatory membrane was also there. Visualization was very difficult and epithelium is being removed, and the status of IOL was not sure, like maybe it was decentered when we looked into it, and we created a scleral flaps for glued IOL, and sclerotomy is being opening is done, and illuminator placed over the cornea makes us the visualization of your needle entry wherever you are doing. And after once that is done, we try to score the desmoid membrane. You actually, since maybe it was because repeated air injection was there with a lot of inflammatory reactions, so the desmoid membrane initially started peeling very easily, and but once we were going into the inferior part, we saw that the desmoid membrane was very well attached to the iris tissue, so we had to use a micro scissors to cut the desmoid membrane from its peripheral adhesions. So with from the iris tissue, we have to preserve how much our iris tissue is there, like without pulling it out. So we carefully dissected the desmoid membrane from the iris tissue. Once it is fully dissected out, we just removed it, and once the graft is out, you can see there is a lot of vitreous which was attached to the desmoid membrane, and the IOL is faintly seen, which is slightly decentered. And since it was a 3-piece IOL, so we went ahead and did a same IOL reposition for your glued IOL. Glued IOL, and the IOL haptic has been held in one MST forceps, with the other one by handshake technique. We externalize the haptic. Once the haptic is out, you go for the other haptic. Again, with the endo-illuminator placed over the cornea, the visualization will become much more better. So you do the vitrectomy to release the vitreous adhesions to the haptics. Once that is done, again, like hold the tip of the haptic. When you're holding the other tip of the haptic, be very sure that you hold the externalized haptic also in hand, mainly because otherwise you may end up having the haptic again back into the vitreous. So once again you're doing the handshake technique, and then we are externalizing the haptics. So this is the glued IOL. Once the glued IOL is done, then you tuck your haptics into the Gabbard-Chariot tunnel. So once the IOL is fixed, then we do the single pass 4-throw pupilloplasty, fix the iris tissue. So with a tenoprolene needle, you passes over the into the iris tissue, and with a 26 gauge needle, you pass the again 26 gauge needle into the iris tissue, and then railroad it with a tenoprolene needle. And once you externalize the needle, you use a reverse Sinski hook or a MST forces to make a loop of it, and you pull out of your eye into a loop. Once the loop is out, then the cut end of your free end of your other end, you can pass it into the loop 4 times and pull it, hold the two ends of your proline suture and pull it across so that the iris tissue approximates. You can do the similar ways to the approximate the iris tissue periphery also. This is the case like where you have secured your IOL, secured your iris tissue, and then you go ahead with your endothelial keratoplasty. So since I have already showed you the initial steps, like I'll just skip it. Just a moment. I think I'll stop here.
Thank you, Dr. Sumati. I think we'll have to wrap up because I think we'll have to give the hall to the next session. Thank you so much. If anyone has any questions, we can take it. Otherwise, offline, we can just discuss whatever doubts you have. Thank you.